Next, we have up our guest plenary speaker for the morning. WillNutland is the co-founder of Prepster, a program that seeks to educate and agitate for prep in England and beyond. He's worked at the UK's Terence Higgins Trust as head of health promotion, as a local authority public health specialist, and recently as a researcher at the London School of Hygiene and Tropical Medicine. We're honored to have Will here. He crossed an ocean to be with us, and I think you'll find that there are a lot of similarities with the work he's done with the work we're doing around prep here in British Columbia. Thanks, Will.
Thank you. Thank you, Jodie. It's such an honor and a pleasure to be here. I also want to acknowledge that we're currently on the unceded territory of the Musqueam, the Squamish, and the Tsleil-Waututh people. Jodie was right. It's 2007, 10 years ago. I was last at this Gay Men's Health Summit, and there are two things we absolutely agree on. First, I want to acknowledge and celebrate the mentorship that Rick and Terry have given me over the last 20 years. Can you believe it's been that long? And I also need my slide. It's moving on, so okay. And I also want to say, Jodie is right, you are a one hot crowd. So, is it possible to get my slides? Is someone trying there? Okay. I'm going to carry on anyway. So today I'm going to be spending some time talking about the fight for PrEP in England. And unless I specify otherwise, I'm only referring to England. Each nation in the UK has its own devolved health system. Scotland right now has provided PrEP for free for everybody who wants it. Wales is providing PrEP for people on a clinical trial, kind of on a clinical trial. And if you live in Northern Ireland, well, if you live in Northern Ireland, you're kind of fucked. Oh, nice bleep. Why does that do that? No. Don't change the spelling.
Where's it? The slideshow. There we go. I don't use this.
It's from beginning. Bless you. Thank you.
Thanks. I'm gonna steal that. There we go.
Ah, great. Okay. So I am going to be only focusing on England, and I'm going to show you what we did in England, not because I think we've done it best or that we've done it better, but I do think we have some lessons to learn about how we've done PrEP over there. And I'm also encouraged over the next couple of days to hear about what you've been doing and to take that back to my colleagues in England and the UK, and because England is right now very firmly embedded in the European Union, to share it with my European colleagues as well. Yes, I did vote to remain. So this summit has a focus on combination prevention, and it's worth remembering and celebrating the steps we've made to date, in the UK at least, with combination prevention. Certainly if you're a gay or bisexual man in England, your knowledge, your access, and your ability to access PEP has never been greater. If you're diagnosed with HIV in the UK, you're going to be offered appropriate HIV treatment within days, if not hours, of that diagnosis. And we now know, and we know especially thanks to the recent advocacy of the U=U campaign, that someone with HIV on treatment cannot pass on HIV if they have an undetectable viral load. And thanks to vast improvements in HIV testing technologies and approaches and ethos towards HIV testing, vastly more people are getting tested for HIV, and we're starting to make a dent in diagnosing undiagnosed HIV. This is a graphic from Terence Higgins Trust's brand new HIV Testing Week campaign. And each of these are fantastic achievements and celebrations. And there's a but, and it's a big but. Each of these things were all delivered with at least 5 factors. Firstly, there was strong, clear, articulate government policy that championed, resourced, and prioritised these approaches. Second, most were assisted by a health service capacity building initiative for staff with a clear implementation rollout. Third, most were championed by interventions including massive media interventions by our national HIV programmes. Third, some were supported, financed, and developed in conjunction with drug companies or technology companies. And fifthly, all were supported by strong leadership from our community-based organisations. So why not PrEP? This is England, actually London's first government-funded HIV prevention programme that explicitly acknowledges PrEP. It was launched last month to coincide with the new PrEP Impact Trial, more of which later. And it's a great initiative, I welcome it. But why has it taken so long? What is it about PrEP that means almost 7 years to the day that the world's biggest clinical trial on PrEP in MSM was published, that we're only now talking about PrEP in our national HIV prevention programmes? What is it about PrEP that led to a collective silence, a collective inaction, a collective dis-ease and discomfort with PrEP that means that many of our leading community-based organisations, not just in London but globally, have failed to grasp the impact that PrEP can make and have failed to understand the urgency of implementing PrEP for our communities? Why have our governments failed to resource PrEP or drag their feet so reluctantly to remove bureaucratic hurdles that we've had to take them to court to make PrEP available? Why has PrEP not been championed by drug companies or by health systems or by organisations? This inaction and inability to take leadership is exemplified for me in this response to the WHO announcement in July 2014 that PrEP should be offered to all MSM. One of the UK's leading HIV leaders at the time said this: "PrEP is an exciting approach and is likely to be one of a number of ways in which we reduce the spread of HIV in the future. However, we need to evaluate how effective it will be in preventing HIV amongst gay men. Until the results of trials are known, condoms and testing remain the best weapons against HIV." Why in 2014, over 3 years after results of the IPREX trial were published, were we still saying we need more evidence? Why in 2014 were we still stuck in a mantra that condoms and testing are our best weapons? We've known about PrEP for at least a decade and a half. Here's a BBC Online article from 2003 that I was quoted in. Not a very good quote, actually. But why the inaction and why the foot dragging? So I'm going to give the game away. I'm going to tell you how the chapter ends, at least in England, if not how the book ends. I think we're a little way along from that. It ended well. And it ended well with not one single pill of PrEP being put into the bodies of people who needed it by our National Health Services. It ended well because a bunch of DIY kitchen table prevention activists organised, cajoled, persuaded, educated and agitated using a combination approach to that agitation. The story of how Prepster started began way before we launched the website, but grew out of a sense of anger, a sense of frustration, a sense of rage that our HIV organisations had dropped the ball on PrEP. Our activist organisations were broadly being incompetent in forging change around PrEP, and our Department of Health and bureaucracies were concerned about how much PrEP would cost. In early 2015, I started talking to frontline outreach workers who said they had no reliable and consistent sources of information to give to men they were encountering about PrEP. And HIV prevention workers were saying that organisations had no consistent policy on what to say about PrEP. And as we're seeing, some of our leaders were stalling PrEP by saying it was something for the future. So what did we do? First of all, we started to agitate. We put the action about how to agitate for PrEP right into the hands of people who might need it. By creating a set of tangible, easy actions that individuals could take, we built a coalition of people who previously hadn't known where or how to advocate or agitate for PrEP. And a number of the HIV NGOs then came on board, and Prepster tapped into a new demographic of people who hadn't previously been involved in HIV advocacy. We put agitation right at the heart of what we were doing. Not least, we reframed a debate that said that individuals themselves are the most productive and powerful resource in forging change and attitudes by talking to their friends about PrEP, by coming out about being a PrEP user, by talking to people about how PrEP can make sex more pleasurable, can reduce stress, can increase intimacy, as well as reducing HIV. We said, you are the greatest resource there is. And then what else did we do? Well, when Prepster was launched, we had no money. So here's an example of a condom pack that we produced, hand-folded, put together and dropped right into the hands of guys who we knew needed to know about PrEP. Handmade in my neighbourhood back in London, this is probably called an artisanal condom pack, and you could probably get about, I don't know, $10 for it. And then we made a film that talked about the fight for PrEP. It's called PrEP 17. You can watch it on our website, and took it all over the country, talking to hundreds and hundreds of people about PrEP and PrEP advocacy. An important note is that every step we brought PrEP users and people who had tried to get PrEP but for whom it had been too late right to the forefront of everything that we did. This wasn't about education done by others for us. This was about education done by us. And there's nothing quite as powerful as being able to talk to someone about your own issues about using PrEP, how side effects impact on you, rather than abstract concepts about what side effects might be. We built capacity, providing training, support, and resources to wannabe advocates, especially in communities underserved by PrEP education. Counterintuitively, we provided and produced condom packs, a great way of getting PrEP information into the hands of condom users. That's combination prevention, huh? But also because of the debates around sexually transmitted infections and PrEP. One thing to note on our packs and our posters is that we always use the language, could PrEP be for you or someone you know? Because PrEP isn't for everybody, and lots of positive, HIV-positive people we were talking to wanted to know about PrEP and pass that information on to their sexual partners. We built capacity around media advocacy by helping advocates be more confident in talking to the media. Again, there's nothing quite powerful during a media interview about being able to talk about your own experience. It's very disarming for all of those questions that get fired at you about slut shaming and STIs and condom use, when you can talk from your own personal experience. So all of these activities were driven by a combination multi-approach to PrEP. All along, we'd been promised by NHS England that they would make a decision about PrEP in the spring or summer of 2016. A working group had been established to look at evidence to support PrEP through NHS England, and a public consultation was about to commence, with an expectation that PrEP would be available within months. And then this happened. Lawyers in NHS England decided that after all, and almost 2 years into an evidence review and a consultation process, that actually the NHS might not actually be the body responsible for providing PrEP, but instead, under new measures introduced in 2012, that responsibility would sit instead with local authorities. So this is where a newfound sense of advocacy came. HIV organisations that for years hadn't worked together suddenly formed a coalition called United for PrEP and really started agitating for change. This involved a combination of advocacy approaches, including things like good old-fashioned letter writing through to street activism. We stormed NHS England's headquarters. We kind of sauntered in, but, I didn't write that headline. And our friends at National AIDS Trust took NHS England to court twice and won twice. In November 2016, the Court of Appeal ruled that NHS England did indeed have the authority to commission PrEP, and these court cases cost NHS England tens of thousands of pounds and thousands of HIV infections that could have been avoided as lawyers argued the case. I want to take a sidestep for a few moments, because at the start I asked why it might be so hard to make PrEP available. And the response from a number of newspapers the day after the August court case might help us to understand why. Where's Jody? Where's my timekeeper? Oh, he's not. Oh, don't worry. So, as someone who had witnessed the gutter press's response to HIV in the 1980s, and its hounding and its demonising of gay men, I never thought 30 years later that we'd still have this crap thrown at us. The Daily Mail called PrEP a lifestyle drug. It was called a promiscuity pill that pitted HIV prevention against other health conditions. Kids with cystic fibrosis, so the story went, would now no longer get a new medicine because the courts were forcing NHS England to provide selfish gays with the pill that allowed them to bear back. I think this response, or at least the fear of this response, sits at the heart of why PrEP has been so difficult to grasp. Not only is PrEP about sex, it's about sex between men. And those of you who've been following closely the story of PrEP in England will know that in addition to the formation of PrEPster, there was another parallel process going on. Unbeknown to us across the other side of London, two guys, Greg Owen and Alex Craddock, were developing exactly the same intervention and the same idea as us. And within about 2 or 3 days of each other, our websites launched. Now, if you ever manage to get me and Greg in the same room and probably give us a couple of beers, we really like recounting the story of what we thought of each other as we walked away from that first meeting that we had in Soho. There's actually someone tried to make a podcast about it, but I don't think it ever got done. It's probably just as well. But we actually became firm friends and firm allies, and the two projects started working together in coalition with a gentleman's agreement about what each of us would do. And the first thing we started to work together was to test the online PrEP that was listed on I Want PrEP Now. This is actually a photograph of my blood taken at the Mortimer Market Centre in Tottenham Court Road. I started to act as a guinea pig, doing test purchases and having therapeutic drug monitoring tests done on my blood. This couldn't have happened without the support of clinic activists, some of whom still stuck their neck out to ensure that PrEP support services were put in place, often underground and often covertly. And as hundreds more people had their PrEP, who had bought their PrEP online, started having therapeutic drug monitoring tests done, we started to become increasingly confident about the integrity of online purchase generic PrEP. None of us expected what happened next. Even more so because not one single person had yet been provided with free PrEP on the NHS. In December 2016, a handful of London clinics announced a 40% fall in HIV diagnosis in men in their clinics. I remember at the beginning of December being in a closed meeting with about a dozen of us sitting around a table as each of those 4 and 5 clinics, one after the other, reported their falls in diagnosis. None of us could believe what we were hearing. And as we said at that time, something extraordinary has happened. Now, I don't want to give all the credit to PrEP, and I think you were right at the start to say that. But we know that there's been a massive increase in testing and a push to provide treatment as soon after diagnosis as possible. So this wasn't just about PrEP, and nor was it just about Dean Street, because even though they've got most of the publicity, falls were happening in a range of other clinics. But HIV diagnosis did start to fall sharply at the time when PrEP became available online. Combination prevention is clearly a factor, but I'm convinced it's PrEP that's the major factor. But are enough people using PrEP to impact that kind of fall in diagnosis? The problem with what we call PrEP in the wild, so buying PrEP online, is that we have no reliable surveillance data to better answer questions about PrEP use, but we do have sales data. And Dynamics, the new kid on the seller's block, are the only seller willing to share any sales data with us. And from that data, we now guess that between 8,000 to 10,000 people are self-sourcing and using PrEP in England alone. That's a lot of people, but the further problem with PrEP in the wild is it enhances health inequalities. So in order to be able to buy PrEP, I need enough disposable income up front in my back pocket to be able to buy it. And there are lots of us that don't have that disposable income. I need an element of social capital. I need to know the right people to connect with, and I need to be able to know the right people who are going to help me to navigate the quite complex buying systems. I need a safe space to have my prep delivered to. So if I'm a young queer person living at home with my parents and I'm not out to them, they might not like that a package of drugs arrives. They might not like, as been happening in the UK, letters being delivered because your packages have been seized by customs because they want a value-added tax to be paid on it. Or you might not have transport to be able to go across the border to be able to pick it up. So what happened next with the NHS court case? Well, in their wisdom, NHS England decided that we needed more evidence about how to implement PrEP before we made it finally available. And so in December 2016, a new trial for 10,000 people was announced. That new trial was due to start in April, and then in the summer, and then in September. And the first clinics finally opened in October. The good news about the trial is that it's a trial, they've cast it as a trial so that they can use cheaper generic PrEP. That means more people can get PrEP for the budget that's available. The downsides and the challenges are that there are strict eligibility criteria, so if you don't fit that criteria, you don't get free PrEP. That there are only 10,000 places, and we already know that there are probably around 10,000 people already buying PrEP and using it. So if all those people who are buying it themselves transfer to getting free PrEP on the trial, we're not increasing the numbers of people in the UK who are using PrEP. And it's only available in sexual health clinics, which is a real disincentive for some populations to get PrEP. There's also the danger that the trial will fill up with exactly the kind of people who already know about PrEP. Filling up spaces, leaving behind people like trans people, people of colour, migrants, and young people. The trial needs smart, resourced outreach to communities that currently don't know about PrEP and who don't know about the benefits of it. And if we try to fill up spaces with just people like me, then we've failed. We've also failed if the benefits of PrEP are only seen in large urban centres like London. First data slide from me. The biggest decreases in HIV diagnosis in the UK are happening in London. There are small and marginal decreases in HIV diagnosis outside of London, but the bulk of the fall is happening in London. Now, this is a gay men's health summit, and so it's right that our attention should focus on gay men. But as a PrEP activist, I want to be equitable in how PrEP is accessed, and I want to see PrEP available for all who needs it. This slide, my second slide, shows UK trends in heterosexually acquired HIV over the past 10 years. Again, we've seen a remarkable fall in HIV diagnosis, but this fall is a very different picture than that of gay men. The fall in diagnosis is almost certainly entirely driven by changes in UK immigration policy. That is, far fewer people who already have HIV are arriving in the UK from countries with a high HIV prevalence, such as Zimbabwe. That's not a success story, because those people still have HIV. They're just not having it diagnosed in the UK. Nor is it a success story that heterosexual and heterosexual men in particular are way more likely to be diagnosed with HIV late than are gay men. Many of those heterosexuals are black African men. So the successes of combination therapy, including access to HIV testing, are not being shared by us all. Jodie, how much longer do I have?
We're running ahead of schedule,
Good.
Which is a real treat. So you're good until 11:15, but if you wrap early, we'll have an extra long break.
Good, okay. So last messy slide. Don't look at it, it's going to hurt. So I love that we just heard about getting to zero, ending HIV, all these amazing kind of mantras. Getting to zero is the one that I keep hearing about. And as we start talking about getting to zero, our attentions need to move beyond our own communities and beyond our own nations. Sure, I can see a time when HIV incidence in MSM in places like London can be pushed right down. Dean Street in Soho used to diagnose about 70 gay men with HIV every single month. Last month, that fell to single figures. But the numbers of UK-born heterosexuals acquiring HIV abroad is rising. And although the number of people born abroad who are acquiring HIV abroad but are being diagnosed in the UK is falling, there are still 600 heterosexuals a year getting HIV this way. So if we want to get to zero in the UK, then we need to be internationalists and to fight for PrEP and combination prevention in the places these people are acquiring their HIV. We can't just focus on our own communities and our own nations. This is a call for action for local and global advocacy. We also need to be challenging PrEP stigma and slut-shaming, and I've been asked by Jodie to hold any further conversation about this until the session on Saturday, and that's fine because I can jump ahead of myself. So I'm going to start concluding with 2 final slides that pose some questions and pose some challenges. The first is that I'm going to make an argument, as I've done today, that as we look at combination packages, we need to be looking at combination prevention, combination activism, combination populations, and combination people. What might combination prevention look like? Well, we need to use combination approaches. So doing PrEP or other HIV prevention or any other health work must move beyond information giving. Information giving has become incredibly popular across Europe because everyone likes to see their organisation branding all over nice billboard posters. From my conversations last night, I'm really impressed with some of the non-information giving interventions that are being done across Canada, so congratulations on that. But it also needs to include capacity building, generating and supporting activists, and we and our organisations need to see advocacy and activism as valid health promotion activities, remember the Ottawa Charter, as well as the other activities that we traditionally see as prevention. And what about combination activism approaches? Activism needs to have new and different approaches. Letter writing, court cases, street demonstration work all still have a place. But let's remember that the England fall in diagnosis happened before PrEP became available on the NHS. That was driven by activism of a different kind, including facilitating the purchase of generics. We need to take approaches that ensure that no one gets left behind. Our combination prevention approaches need to reach out and to reach deep into those communities and populations that aren't first in line for these approaches. And whilst PrEP has the potential to change the face of HIV, it also has the potential to massively exacerbate those inequalities. Fourthly and finally, we need to have approaches that recognise that these changes happen not because of a small select number of us who are always in the spotlight, but because of the hard graft and commitment of hundreds of us working together to foster change. The changes in London didn't just happen because of me and Greg. They happened because clinic activists joined us, because hundreds and hundreds of people attended the events we hosted, and because thousands of people took their HIV prevention into their own hands by sourcing online generic PrEP. This is not the story of a small bunch of heroes or saviours. I'm not making a dig at anyone there, by the way, in case And finally, and really finally, what else can we learn? So first, I think what we've just seen is something remarkable. The confluence of access to generic PrEP, the ability of online global networks of people to share information, and DIY prevention activism that has made this happen. Isn't it now remarkable that someone in Canada can get cheaper generic PrEP that they found out about through a Facebook group set up by an American activist, that was quality tested by people in London, via a website in Australia that's imported via India, via Europe, and into the USA, and is then forwarded or brought across the border into Canada. Nice work, guys. Second, for me, what's happening with PrEP raises some questions about the future roles of our community-based organisations. Certainly in the UK, most of our CBOs shied away from getting involved in this kind of new activism. And it's remarkable that leadership has broadly come from individuals outside of the HIV and health sector. I think we need to fire a warning shot, folks. Because although there are some remarkable examples of excellent practice in community-based organisations, I think these are the exception. I see community-based organisations that are stale, that are playing it safe, that aren't wanting to rock the boat, that are too influenced by what their funders say and what the funders tell them to do. I'm not sure this model is sustainable, not least when there are outsiders that are driving innovation and change. The models of PrEP provision that I just touched on, driven by online networks and generics, also offer some outstanding opportunities. Access to generics are driving down the cost of health and prevention for individuals. They offer a degree of democratization of health as individuals and communities take control of their own health and their own well-being. And PrEP access offers a potential model for other health conditions, such as cheaper access to cancer drugs. We've got something that other people can learn from. But it also offers challenges and dangers. For example, some sites are offering doxycycline for STI, PrEP and PEP without the same kind of information and support that's been offered for PrEP. And we're already seeing how PrEP in the wild, rather than decreasing inequalities, probably exacerbates them. So finally, as we move to the future, and as we move into the next few days of debates, discussions, learning and teaching, I think we should do so remembering that something extraordinary is happening, and it's happening right now. Not only are the ways of doing health and prevention work extraordinary, but the results are extraordinary too. Our challenge is, how can we make that extraordinary for everyone? Thank you.
So we are ahead of schedule, and it means we have some opportunity for questions. So there are two microphones to the right and the left here. Does anyone have a question for Will? Well, I think that means you were perfectly clear, Will. Any other comments, questions for Will before we wrap and take our break? All right, great. Well, sure.
I'd like to know more on non-informational prevention. Could some other successful examples?
I'm going to go back to this one. I think capacity building, helping advocates understand how they can speak to the media, challenge the media, set media agendas is probably one of the most powerful tools that we can be using to train people. We can produce tens of thousands of pounds worth of brochures and leaflets and literature, but I know that if I go on BBC 4, Radio 4 at 8 a.m. in the morning, the information I talk about PrEP is going to get to millions and millions and millions of people. And I think it's an advocacy tool that we're not necessarily very good at using or haven't been very good at using. By running the media training, we trained 30 PrEP activists who said that they already had some media opportunities but wanted to do more. So we taught them very basic media techniques, and then we coached them and looked after them and tried to filter media interviews through to them so that they were actually getting practice on the job. Hi.
I have a question about maybe kind of some of that. With the negative press that you use the mic, please get your questions.
No, there are two mics in our aisles right here. Thank you, in the back. It's also good for the recording, right? So we're recording this session. We make it available on YouTube so that people can watch it if they weren't able to come today. So thanks.
You didn't tell me that.
Hopefully.
You're live.
Okay, so with the negative press maybe that you did receive through the NHS, the news slides that you showed, was there a response from Prepster that you were able to put out, or how did you respond to that to kind of maybe negate some of those?
The Daily Mail is an incredibly powerful publication. It's one of our most disgusting, disgraceful, I'm saying this because now I know I'm being recorded, publications that you could possibly think of. They helped to drive the agenda around Brexit. They're hugely misogynist, they're anti-women, they're anti-migrant, and it's very, very hard to challenge their rhetoric. Collectively, what we did with our colleagues from like National AIDS Trust and Terence Higgins Trust was to write responses. Part of the problem with that reporting was that someone in NHS England's press office helped to drive that agenda by putting out a press release that we then had to make a complaint about. We felt that there was no other health condition when they would have talked in the way they did, as they did about PrEP. So there's not a lot you can do. They've put it out there. They're trying to set an agenda. You have to just keep trying to do stuff that counters it all the time. There's no quick fix for it. Hello.
Hi, Will. Damon Jacobs here. Thank you so much for a great presentation. You mentioned the impact trial that's currently being filled in the UK. I'm wondering two parts. What is being done to try to meet the racial and gender discrepancies that are taking place? And or what would you do if you had the time, the resources, the money, the activism? What would you suggest people do in order to not have those discrepancies be so vast?
Sure. Well, the first thing I would do is not run it as a trial, but it's running as a trial. The first thing, so there are 10,000 places on the trial, and right now 20% of them are ring-fenced for what they're calling non-MSM communities. So they know that lots of white gay men living in places like London will rush into the trial, but they basically put a ring fence around 20% and saying, you gay guys can't get into these places, at least in the first instance. And I think that will be reviewed over time. So the concept is that by doing outreach, by going and talking at meetings, by doing some advocacy, we can increase knowledge about PrEP, for example, with Black African women. So that's what we're trying to do on a kind of a structural level around the trial. What would I do to try and make the trial more diverse? Well, if you want to go and look at Prepster's website, there's an action page that tells people what we think we can do collectively to increase diversity of the trial. And that includes having materials about the trial that aren't just full of cis gay guys. But also doing things. I mentioned earlier that one of the obstacles to the trial was it's only recruiting in sexual health clinics. And we know, for example, that some communities in England don't want or don't like to go to sexual health clinics for their sexual health care. They would rather go to their family doctors. So, for example, lots of Black African women don't want to walk in to a sexual health clinic. If they've got some problems down below, they'll go to their family doctor. Family doctors aren't recruiting for the impact trial. So one of the actions we're encouraging is for us to identify the parts of London mostly where there are family doctors with large populations of African women and African men, and informing them about the impact trial, and even trying to develop chaperoning opportunities so volunteers might meet with those people in the doctor's surgery and then help them actually get them to the clinics where they can enroll on the trial. Those are some of the examples.
Thank you.
Well, I have a question for you. There are sort of a couple of ways to look at access. So first of all, a government-sponsored program, which is one of the things that we're advocating for. But I'm wondering if we also know we have to do work with healthcare providers and with gay men in general. Could you elaborate a little more on perhaps Prepster strategy or any strategies that are going on in the UK around educating healthcare providers so that they're more ready, willing to write the scripts and support their patients?
Yep, so one of the advantages of having a trial, because there are some advantages of having a trial, let's be honest, is that we can start to capacity build those clinicians who over time, those services over time, that will start providing PrEP when it's fully rolled out. So One of the problems with the impact trial, and one of the reasons it's taking so long to get set up, is that there are probably going to be about 200 trial sites. That's a massive number of trial sites for a fairly small funded trial. And that's because they're trying to get a sense of equitable pattern of PrEP availability on the trial across the whole of England. And any clinic that enrolls will be given a minimum of 20 spaces. Now, we know from talking to some of those clinicians, if they're out in the middle of nowhere, they're saying that our clinic, there's no way we will fill up 20 spaces. But what they are doing is having capacity building, training, knowledge transfer through the trial about PrEP, so that in the future they will be able to provide PrEP to those people. That was really hard answering a question and not looking at you.
Sorry. Any other questions for Will? I see Philip coming to the mic.
Oh, it's going to be a tough one.
It's a tough one. It's going to be tough.
Hey, Will.
Hey, Philip.
Hi. So I just want to pick up on something you said about the information piece. So the context may be different in the UK, in that maybe there was more resourcing of sort of the information piece in the UK for HIV or for gay men. So in Canada, I wouldn't want us to give up on the information piece, because I think the lack of resourcing for information, and I don't mean condom packs that are prepared and distributed. I mean like high level, large scale, sustained social marketing campaigns or social communication campaigns. I think there's still a role for those. So in Canada, I wouldn't want people to walk away with a message here that maybe we should downplay the role of information here. I think it's never been funded enough, because I don't think our lives have been valued enough. So it's something to, I think, continue to advocate for.
I absolutely agree. I think my comments were directed towards the fact that, for example, our National HIV Prevention Programme is mostly print or online media, and now does fund some face-to-face work, but most of the face-to-face work on that national programme is no longer in existence. And that means that those people who either don't have English as a first language, or maybe don't have very high literacy skills, or don't understand some of the nuances of the technicalities that are going into that written information, are losing out. And that's enhancing some of the health inequalities.
Yeah, and I think that's an important nuance. And I'm not actually being critical of what you said so much as just to make sure that we remember here that in the 30+ years of this work, that we've never had an appropriate and adequate investment in the work. Yeah. And some of that would have, had we followed best practices, included more information.
And Philip, as a kind of an add-on response as well, the other thing, kind of didn't say it in my presentation, is that my concern is that PrEP has become this brand new, bright, shiny thing that everyone's getting excited about, and our funders, our planners, ourselves will take our eye off the ball of all of the other stuff. And there's some evidence emerging from London from a couple of years ago that some of what I call that bread and butter HIV and health work is really falling apart. So my old colleagues at Sigma Research looked at the 2004 Gay Men's Sex Survey findings and found that men's knowledge of stuff like where they could get condoms from, how to use condoms, was starting to diminish. And we need both. It shouldn't be an either or.
Nice, thanks.
Do you think we have made much progress moving away from the notion that PrEP is a way to promote promiscuity among any part of our community that enjoys sex? Have we reached a tipping point where the people who think this is a party drug as opposed to a health preventive measure, who's winning that conversation?
So I have two kind of almost opposing views on this. I actually don't really mind if people do see it as a party drug, if that's how they're using it and it's stopping them from getting HIV. My concern is that, and we're seeing this come out in London, that the narratives about who PrEP is for, slutty people, people who have loads of sex, people who go to saunas, people who go to bathhouses, is starting to mean that some of those other guys who might not have loads of sexual partners but are still being exposed to HIV are not seeing that PrEP is for them. And I think that's the danger that's going to play out.
Thank you.
Hi. You mentioned that community-based organizations in England have been slow to advocate around PrEP. I wondered if you could say more about that. Why is that? Has that changed? Thanks.
I think it's changed massively in the last year or two. I think the irony is that NHS England's decision to go to court around, or us taking NHS England to court, massively increased knowledge about PrEP, massively put PrEP on the agenda, not only the kind of the government's and the planners' agenda, but on the agenda of our community-based organisations. I think there are a couple of reasons why there's been inaction from community-based organisations. One of them I kind of mentioned and alluded to in my presentation, and that's around what funders might say, what funders might do. The National HIV Prevention Programme that's been running for almost 2 decades, has only just started publicly talking about PrEP, and has only just now mentioned PrEP in its mass media interventions. And I think that was because of that programme of work is funded directly from the Department of Health, and I'm saying, I don't know for sure, the people who run that programme were worried about what their funders might say if they were being seen to promote a technology that wasn't yet seen to be legitimate. I think there are some other organisations that I've definitely encountered a sense of being really scared about the implications of PrEP, not knowing what to say, finding PrEP too technically difficult to train staff or volunteers around. Clients were coming in, service users are coming in with difficult, awkward questions that they don't know the answers to. So PrEP, as well as being this bright, new, shiny, fantastic thing, is also really challenging some organisations' ethos and practice. I mean, isn't it easy just to go out and give out a bunch of condoms and talk about use a condom every time? PrEP doesn't make things simpler. PrEP makes things 100 times harder. So I think those are some of the reasons. And, you know, I think there's a whole thing with a bunch of people who really have a problem with the concept of sex without condoms.
Great, thanks. I'm glad we waited for a few questions. On behalf of the CBRC, I want to thank Rocky, I want to thank his mom, Florence, I want to thank Elder Bill White, Mark Gilbert for setting the tone, and Will for being our plenary speaker.